premise of advanced airway. So this is my suggestion to all the residents, especially those who are starting your career in emergency medicine. Never forget these 3 golden rules throughout your career in emergency medicine. So the 3 positions which are very, very important for us to have a successful airway placement. 1, how do you position yourself? 2, the patient's position. And the 3, where do we keep your laryngoscope blades? Let's quickly look at how do we position ourselves when we intubate. Right? I'm going to show a few pictures in the forthcoming slides. But what I would recommend here is clearly stand further back with straighter arms and your back. Hold your laryngoscope closer to the blade. The arm should be only modestly flexed at the elbow and adducted, and do not bend in right angles. By application of force, the intention here is not to lever your scope, but to give the force so that you can lift the laryngoscope up. So let's look at this picture where my resident is trying to intubate a patient. As you can clearly see in the first picture, you can see he's bent forward, his elbows are flexed. That's not the position you need to be while you are intubating. If you look at the second picture, you can clearly see now how he stands back and the elbow is not flexed as much. It's only flexed very minimally. Right? That's the right position for you to stand when you intubate. And also look at the space between the head of the patient and head of the bed or the end of the trolley. So there's a lot of space in between. That's not the way you place your patients. The patient's head end should be ideally at the end of the trolley, closer to you. When you begin with the wrong position, that will lead to a wrong axis, which we are going to see in some time now. And what you will end up doing is basically you'll go more closer to the patient, trying to look for the vocal cords, which is absolutely not the right way to do or right thing to do, right? So does the patient's bed height really matters? It's something which we overlook. Clearly in an emergency department, it's quite busier. We don't really pay so much of attention to the height of the patient trolley. Clearly, that does make a significant importance in airway management. The patient must be in the center of the bed, and his head must be positioned as close to the upper end of the stretcher. And this is an interesting study from British Journal of Anesthesia, where they looked at around 300 patients, and they saw that does the bed position really matters. And they tried intubating patients at 4 levels of the operator. 1 at the level of the neck, 1 at the level of xiphisternum, at the level of the lower ribs, and 1 at the level of umbilicus. So it is found that when you place the patient's trolley at the level of your umbilicus and slightly above that, the chances of you getting your intubation right in the first attempt is going to be significantly higher, irrespective of how much of a difficult grade of intubation it is. So it is recommended that you keep your bed height at least to a level of umbilicus or slightly above that. So that's about how do you position the bed and how do you position yourself. Let's quickly look at how do you position the patient. The aim of the patient positioning is basically to align 3 axes together. They are oral axis, pharyngeal axis, and laryngeal axis. And they have to be aligned, allowing the line of vision to fall at the laryngeal inlet. And this was described actually in 1936 as 3-axis theory, and we call it as sniffing position. So I'm going to show what is a sniffing position rather than trying to read what a sniffing position looks like in the forthcoming slides. So clearly these are the 3 angles which we need to align: the pharyngeal axis, the tracheal axis, and the oral axis. So once you align, you pass your blade, and your tip of your blade lies at the vallecula. That's how you create more space for you to visualize the vocal cords. So let's have a look at how to align that. If you don't align your patient's airway, the patient occiput is not elevated, and if the neck is not in flexion, it creates a steep visual angle, as you can see in the first picture. And what you will end up doing is you'll try moving closer to the patient's mouth, trying to search for the vocal cords. The second picture is the correct method, where the occiput is correctly elevated, placing the patient in a sniffing position, allowing the visual axis to align with the airway axis. And it is found that sniffing is better when it comes to any difficult level of intubation. So sniffing position has highest first pass success rate. So once you place your blade in the valvula, if you place it in the proper position and lift, clearly you're going to see the vocal cords as shown in the second picture. But improper positioning of the blade or the tip of your blade, or in fact improper selection of a wrong size blade, in spite of your sniffing position and your position, you may not still see the vocal cords when you intubate. So these are some of the other positions which are recommended, like ramped or stacked or head elevated laryngoscopy position, especially in obese patients where you're trying to align your xiphoid process with the external auditory meatus. In the first one, where you use certain blankets, or you might use a troop elevation pillow to achieve the same. But what's interesting is, there are studies, and this one is a recent meta-analysis of about 632 study subjects, which basically has found that clearly sniffing or ramped makes no difference. So even in your obese patients, as long as you follow the basic steps of positioning yourself correct and putting the patients in sniffing position, we should be still able to intubate this patient successfully. So these are other possible angles where you can try intubation. This is on upright intubation, where there are a few interesting studies, especially with residents trying to intubate for the first time or learning intubation. They found upright positioning has better success rate as well. So the recent article in AJIM in 2017 actually says the upright intubation position has a first pass success rate of about 85%. So when we say upright, this is placing your patients above 45-degree angle. It may not be feasible in all your patients in ED, especially with trauma and other patients. But however, it does help certain times. And if anybody who's learning intubation, if you have an opportunity to try it, you may. So let's come to pediatrics. Is it any different from adult positioning? Yes, there are certain anatomical considerations you need to remember. We all know the occiput is quite large in pediatric age group. They have a large tongue. The tonsils and adenoids are larger. The vocal cords are placed much higher. They've got a weak hypoepiglottic ligament, floppy epiglottis, a short and a narrow trachea, and also an anatomical subglottic narrowing. So now how do you position airway for pediatric age group? Clearly 3 steps. Align the glabella with chin, open the anterior neck space, and try to align the external auditory meatus horizontal with the suprasternal notch. So this is the position in pediatrics, where you see clearly the external auditory meatus is aligned with the xiphisternum, the neck is open, and also the chin is aligned with glabella. So this is one of the easiest positions for getting your intubation right in pediatric age group, and you may probably use a headrest or a shoulder roll to achieve this position. So quickly to summarize, I want to reiterate to all of us that bag and mask is actually a very important skill to learn before intubation, and it's an essential skill for all of us emergency physicians. And if you are a resident in this Congress, I would strongly suggest master the art of bag and mask first. Keep the patients as high as possible. Ensure the bed is at least to a level of your umbilicus and above. Keep the patient's head in the trolley closer to you or closer to the head end of the trolley. Don't have any space in between. Align the 3 positions, 3 angles. That's a sniffing position. Stand back and don't flex your elbows too much. If you don't get your airway or vocal cords, don't go closer. You should rather go backwards, trying to align those 3 ankles. You can try ramp or stack position in obese patients and ensure that the tip of the blade is also in the right position, where in adults it's in the valvula, whereas in pediatric age group, you will actually include epiglottis as well when you are trying to do a scopy to see the vocal cords. And if you are a resident learning intubation, try upright intubations. You might probably find that a bit easier. And with that, let me thank the organizers once again for giving me this opportunity here, and extremely happy to be back here on the stage. Thank you.
Thank you very much, Dr. Saraman. This is very important object for emergency medicine. Yes, we can take some question. Dr. Behçet.
Thank you very much, Dr. Kumar, for a nice presentation. My question is about the position. You mentioned about the importance of the position while we are doing the intubation, especially the position of the provider, the position of the patient, and also the position of the requirements. That's really very nice that I'm satisfied with it. I think you read many papers while you were preparing for this presentation. Just my question is about the corona corruption. In the beginning of the corona, it was mentioned many times everywhere and put a barrier between the provider and the patient while you need to intubate the patients. Well, do you think it was a right way, or do you think we did it wrong, very harm the patient? This is my question. Secondly, you said this is your 9th time being in Turkey. Thank you very much. Always welcome. But unfortunately, for becoming a Turkish citizenship, you need come one more time again. Welcome.
Thank you, Professor Behçet. I'll answer the second one first, and yeah, hopefully I'll get it next year. And with regards to your first question, I think it's a very important question, because at the beginning of Corona, we all tried using those intubation shields and the hood and various fancy-looking transparent equipments, and that did complicate the process a little bit. We also tried that, and clearly many a times it was a bit difficulty to maneuver using the small space which you have got there. But again, as time passed by, we also got a lot of study and research which said using those boxes is clearly not going to be helpful in preventing the spread of COVID. So rather, a full PPE for the operator is a much better option. So that's what most of us moved towards. And we in fact stopped using any intubation boxes or hoods for any of our COVID patients, perhaps in the first wave itself. So during the second wave, we didn't use any such hood. And clearly, we didn't see any incidence of raised COVID cases among the emergency doctors, especially because of getting exposure to the airway procedures. I hope I could answer your question.
Yes, thank you very much. Maybe one more question or comment. Okay. We can announce. I want to invite the list. The last speaker, Göksu Afacan Öztürk. Please. Göksu Afacan. Her topic about awake intubation ER.
Hello everyone, my name is Göksu and I'm from Istanbul. I try to summarize your awake intubation in ER. Awake intubation is a placing endotracheal tube in trachea while the patient continues to breathe. The principal advantage over rapid sequence intubation is that you not take away the patient's respiration or airway reflex, which makes the process safer in many circumstances. The disadvantage is that the patient's personality, movements, as the patient's airway reflex must be managed, and it may take time. And even when done well, the review won't be yet as good as in paralyzed patient. Instrumenting the back of the throat may cause gagging to possibly vomiting through this quiet and unlikely to lead to clinically significant aspirations. And the more difficult airway features, the less urgent the intubation, the more likely you should intubate awake. Patients who are at high risk to vomit are not good candidates for an awake technique. In general, awake intubation should be preferred in airway does not need to be immediately secured, significant risk for a difficult airway, low risk of vomiting, compliant patient, and endotracheal intubation via the nasal or oral route is feasible. Performance of endotracheal intubation can be viewed as several interconnected steps. These include assessment of the airway, physiological preparation of the patient, pharmacological preparation of the airway, and the preparation of equipment and personnel. We are working in the emergency department, and this, the physiological preparation of the patient is the important one for the preparation. Just because the patient is not compliable to this procedure, you cannot intubate him or her in the awake manner. The procedure of endotracheal intubation itself divides into essential monitoring, pre-oxygenation, and general local anesthesia, as you already know all of this. And the majority of endotracheal intubations are performed in elective manner. Huge amount may be done in the emergency departments. If I can ask you something, this one is the take-home message. Awake tracheal intubation must be considered in the presence of predictors of difficult airway management. Cognitive aids such as checklist is recommended before and during performance of awake tracheal intubation. Supplemental oxygen should always be administered during all of the procedure. Effective topicalization must be established and tested, and lidocaine should not exceed 9 mg/kg. This is the lethal dose for the lidocaine. Cautious use of minimal sedation can be beneficial, but sedation could not be used as a substitute for inadequate airway topicalization. If you cannot topical anesthetic to the patient, you cannot replace it by the general sedation. If you want, you can use that. The number of attempts should be limited to 3, with one further attempt by more experienced operator. If you can't be able to intubate patient in 3 times, let it go away. Anesthesia should only be induced after 2-point check. The visual confirmation and capnography has confirmed correct tracheal tube positions. And also, all departments should support emergency medicine residents to attain competency and maintain skills in awake tracheal intubation. They only really talk about awake intubation for anatomically difficult airways, but I actually think that the physiological difficult airway will be more common indication in emergency medicine routine. And also, I wouldn't be trying an awake approach in the emergency department with an uncooperative patient. This is a difficult airway intubation and difficult mass ventilation table, but the most important indication is unstable cervical spinal fracture. This is a fracture in the cervical spine. You have to intubate it by an awake manner. They make controversial and probably incorrect statement that awake tracheal intubation should ideally be performed in the operating theater, but we have plenty of skilled assistants, drugs, equipment in the emergency department. Also, I will admit, space is sometimes a little short. We need to monitor for airway obstruction, hypoventilation, arrhythmias, and hypotension. Most of this obvious, but the use of antidote is an important recommendation. Workspace ergonomics have an impact on performance and safety, and you have to do a plan for an unsuccessful awake intubation. You have to sedate your patients if all the things goes wrong. And always says that perioperative settings of the cognitive aids such as checklists improves the interprofessional communication, teamwork, and patients of outcomes. A cognitive aid such as checklist before and during performance and awake tracheal intubation is recommended. So we have to use the awake tracheal intubation in 4 things. The first is oxygenate, then topicalize, then sedate the patient, then perform. A lot of things about awake intubation technique. We firstly use anti-CLOX, then dry all of the area, then use topical-like agents, then minimally sedate your patient, then the perform. Awake intubations, a direct or video laryngoscopes is glycopyrrolate is this 0.2 milligram or atropine, but the glycopyrrolate is the chosen one, just because the atropine can have a lot of side effects. Then you can use the ondansetron for may help to decrease the gag reflex. Suction, then dry. Nebulized lidocaine and atomized lidocaine for using the topicalized agents. Then you can perform the pre-oxygenation, position, gentle restraint, then just go with it. This is a summary for the procedure. You have to local anesthetic to the nose, then pharynx, then larynx, but you have to a little bit aid with sedation, and your patient is awake, and you just say, take a deep breath when you perform in laryngeal sedation. The oxygen is important. The administration of supplement oxygen during intubation is recommended. High flow nasal oxygen should be the technique of choice. The topical lidocaine should not exceed 9 mg/kg, and practitioners should recognize that that is not a target but a maximum dose, and in practice it's rarely required. Just because you aid your procedure with a little bit sedation with midazolam. And with all local techniques, local anesthetic toxicity will be in mind, and you have to do something for toxicity, including lipid emulsion should be in place.
Thank you very much, Hannah, for this very nice invitation. It's a privilege for me to be the first speaker of this huge Congress, and I think that what you did in this session is to address the importance of invasive technology as a new opportunity to increase the power of emergency medicine worldwide. I really am happy to address this topic, and this topic is coming as the need, and we will see during my presentation, to work together. Not only emergency physicians, but radiologists, interventional cardiologists, to produce more evidence and publications, as we did into the great network, worldwide academic research organization that is with Watson worldwide try to increase the powerful of publication in our group. And I really appreciate that you put in the backs many journals, because this is the future of emergency medicine, to produce evidence. So let's go now and see, after my disclosure, what are really the needs for technology support after clinical evaluation. Before starting my talk, let me tell you that no technology can support a bad emergency physician, because the best technology emergency physician has is his holistic opportunity to visit the patients and make clinical decisions. By the way, in the last 25 years, we saw an important increase in quality of laboratory testing, especially biomarkers in acute disease and point-of-care biomarkers, but also technology of imaging. So laboratory testing and imaging are going to be the big revolutions in our job to increase the quality of our medical effort and, most importantly, increase patients' outcome. When you talk about imaging, for sure you know that ultrasound have totally changed our ability. Every emergency physician now are able to perform ultrasound, and I'm very proud that we were the people that teach cardiology on how to use chest ultrasound to detect many diseases they were not able to do. But nevertheless, besides the ultrasound that are growing impact, there are other technologies such as point of care, looking at the computer-assisted imaging, but last but not least, the angiography. Angiography is really important, and I think it's something that can really improve our knowledge and also quality of health delivery system. But of course, the issue here that angiography need a cath lab or let's say radiology interventional box that should be as much as possible close to the emergency room. So this is the first example. 250 years ago in my